All right, so it is now 8 o'clock, so I will go ahead and get started, but if people trickle in the next couple of minutes, then that's totally fine too. So my name is Olivia. I am a third year med student at the University of Iowa, Carver College of Medicine. I've been doing virtual rounds with Motivate MD for probably about 8 months now. So I think I probably can recognize some of you guys. I just took a little bit of a hiatus to take step one. So luckily I got my score back today and I passed. So I'm very happy about that and happy to be back with all of you. So today's topic is going to be a surgery topic. We're going to talk about thyroid cancer. And thank you everyone for the congrats. It's a great relief for sure. We're going to talk about thyroid cancer and kind of a little bit of thyroid anatomy and pathology along with that. And I really like when this is interactive. So please feel free to either unmute yourself to contribute or ask questions or put something in the chat if you're not comfortable speaking. Either way works for me. So without further ado, let's get started. As always, we'll go through a case, and that will include a physical exam and differential diagnosis. We'll go through kind of an initial assessment and plan, and then we'll do a little lesson on the pathology. So like I said, this works really well when people participate actively. And I did put earlier in the chat a link to our SOAP note and quiz. If you'd like to get a certificate of completion, then that's going to be something that you'd like to have open. And if that's not working for any reason, then just let me know. So this is what it looks like. I'll give you guys a second to open this up, and we can also do this fun little annotation where we can put our location on the map from where we're at. So I'm here in, oh, hold on, I have my pen on, not my stamp. I'm here in Eastern Iowa. That's me. I don't know really how to use Zoom that well, so we'll just take a couple minutes, and if you guys want to put this on, or if you want to take another couple minutes to load your forms, then you can do that for a few more seconds. But I always really appreciate when people are able to join when we're even in different time zones. Since I know people in New York and on the East Coast, it's probably like 9 o'clock for you. Sometimes, and it looks like we have some people up in Canada as well. So always great to have everyone get together virtually and learn about something that we're all passionate about. All right, I'm going to clear all the drawings and turn off annotation. If I can figure out how. Clear. Okay. So we're going to jump right into our case. We have a 24-year-old female patient who's presenting to clinic with a lump that's just above her collarbone. And she first noticed it about 6 weeks ago. It was just about the size of a pea, and it seems to be kind of gradually enlarging, and now it's about the size of a lima bean. And aside from this one lump in her neck, she doesn't have any other symptoms that are new to her, and so she just wanted to come and get it checked out. So what other parts of the history would you guys like to ask our patient? If she takes any medications? Yeah, if she's having any symptoms. Injuries would be good. Mental health history, anxiety and depression as well. Smoking history, great. Yeah, it's kind of hard when we like don't really have any other information besides she literally just has this one bump. Yeah, family history of cancer, family history of other diseases. Those are all, everything that you guys have said is a great topics to screen for, especially in a patient that has a new problem, but really any patient we'd like to get kind of a baseline history on them. So we'll advance to the next slide. This is a little bit of a busy slide, but it's going to answer a lot of the questions I think that we just had. So for her own personal past medical history, and again, this can be things that you guys put in the subjective portion of your SOAP note. She has a history of varicella at age 4. Does anyone know the like colloquial everyday term for varicella? Chicken pox, perfect. Madeline and Joshua both got that. So she had chicken pox when she was a kid. And she also has a history of anorexia nervosa, but she's been recovered since age 21. So she's been in remission from that for a couple of years now. And aside from that, she doesn't take any other medications, no other significant medical history. For her family history, her mom does have a history of cancer. She had a stage 1 melanoma. And stage 1, if you are not familiar with melanoma, is basically confined to just the upper layer of the skin. It hasn't like infiltrated beyond a certain thickness. And so you're able to basically cure it by just removing the melanoma. If you're interested in melanoma, I did a virtual rounds on this a couple months ago, so you can find it on the website or on the YouTube. But again, that's not really the focus of today. Her father also has a history of hyperlipidemia, which is essentially high cholesterol. So maybe a little bit of increased risk of heart disease there, but this is an otherwise healthy 24-year-old. So we're not really concerned about her heart at this point. And then her sister also has a history of bipolar disorder. So maybe a little bit of concern with mental health, but probably unrelated to her presenting chief complaint today. She does not have any history of any surgical procedures. And for her social history, she lives with a roommate. They do not have any pets. She is a pre-med who is applying to medical school, and she's currently taking a gap year. So maybe going through a little bit of stress, as you could probably imagine. And she is not sexually active. So other things that you guys had wanted to ask about, like sleep quality, if she had any like smoking history, things like that. I didn't include explicitly on this slide, but for purposes of the case, they're not relevant, or they're not contributory, I should say. Those things are relevant for, general health things, but not contributory to this case. And then further review of systems. So this is kind of doing a survey of the whole body and what kind of other symptoms she may be having. So she does not have any recent illness, like no cold or strep throat or things like that. She's not having any throat pain. She doesn't have any weight loss or weight gain, not having any night sweats or excessive sweating. And those things might become a little bit more apparent later in the presentation when we go through some other thyroid pathology. She also does not have any other palpable nodes or masses in the body. So this one that's above her collarbone, we're assuming right now is a lymph node. And if you have one swollen lymph node or one area of swollen lymph nodes, then you also want to check for the other ones in the body, such as like in the groin or the armpits, to see if it's something that's localized to that one area or something more widespread. So luckily, she doesn't have anything that's more widespread. She also doesn't have any GI changes, so no constipation or diarrhea, and her mood has been pretty normal and stable from her baseline. So Adam asking about her anxiety and depression, it sounds like that is not a concern for her today. Okay, moving on. So our differential diagnosis at this point is super broad. I always encourage you guys to not eliminate anything from your differential. And try to challenge yourself to make as long of a list basically as possible from the get-go, and then we can narrow it down from there. So some things that I came up with for possibly just like a swollen lymph node, possibly something to do with her thyroid, and with her family history of cancer. Actually, the most common cause of swollen lymph nodes, especially in the neck, is a simple viral infection. So things like mononucleosis, which is pretty common in this demographic of young adults, can cause pretty significant lymph node swelling. But she doesn't have any other things like a sore throat or fever or anything like that. Something more concerning, again, with swollen lymph nodes could be something like lymphoma. But at this point, we don't really have further information to talk about that. And then some other scary things that we'd want to kind of be extra diligent about checking for would be cancers, like thyroid cancer or other metastatic cancer, like if she did have a melanoma that had spread to her lymph nodes because of that maternal history that she has. So those would be things that we want to rule out with a thorough history and exam. Other things that would be less concerning and less life-threatening would be things like a skin infection, something like a benign thyroid cyst or an adenoma that's not going to be cancerous, or some other thyroid pathology that we don't know at this time, but could still be on the table. So pretty broad differential at this point. All that we have from her history is that she's got this lymph node and some possible family history of cancer. So do we have any questions so far at this point about the history or formulating our differential? And is this pace okay for you guys as well? Are we going too fast or too slow at all? Okay, so Seema is asking, how do we rule out parathyroid conditions? And that's a great question. So parathyroid is, I'll kind of talk about this a little bit later, but it has a different role in the body compared to the thyroid. And usually this would present with an abnormal lab value, specifically the electrolytes of calcium and phosphorus is what that deals with. And we're actually going to talk about if you have low parathyroid hormone levels, how that can affect your calcium levels. But at this point, we don't know necessarily with this lymph node if it's metastatic from a thyroid or a parathyroid. And also the size as well. The parathyroid glands are very, very, very small. So it's unlikely, unless there was a really large progressive tumor that would enlarge them rapidly, that you would be able to feel them on an exam. Great question though. And we'll talk about it a little bit more. So here's our slide for physical exam. And this is on your note where the objective portion is going to start. So we always report vitals first. And her blood pressure is maybe slightly elevated. Normal would be 120 to 120 over 80. And she's a little bit higher than that, but this still isn't classified as hypertension or being an elevated blood pressure. It's just could be environmental factors such as she just walked up the stairs and we took her blood pressure too early, but this is not concerning or remarkable at this point. Her heart rate is also still within normal limits. Normal would be 60 to 100 beats per minute. And for someone of her age, we would maybe think of it to be lower, but this isn't abnormal. Her respiratory rate is 16, which is also normal. Her temperature is 37 degrees Celsius, which is a perfectly normal afebrile or no fever body temperature. And I think is it Nevis or Nivis? I'm sorry if I mispronounced your name, but that is oxygen saturation, which she's at almost 100%. So we're not worried about her oxygen or lung function, and her BMI is 21. So she has a normal BMI. These are absolutely perfect looking vitals with maybe if we remeasured her blood pressure, I would expect it to be normal. So nothing concerning there. On physical exam, I included kind of a full physical exam for everything, but really the one under neck section is the thing that I want us to focus on. So everything else here, general, head, heart, lungs, abdominal, all of that is like pretty normal, unremarkable findings. So to focus on her neck exam, we find that her trachea is midline. There is a 1.4 centimeter firm lymph node right above the right clavicle and a approximately 2 centimeter non-tender nodule of the right thyroid lobe, and also no thrills or bruits. And so I know that's kind of a lot to break down here. So the lymph node above the clavicle is called a supraclavicular node. And the nodule of the thyroid is potentially related to that because they're on the same side, if that makes sense. And then for the thrills and bruits, I don't know how much you guys have learned about like listening to the vessels in your body, but essentially a bruit is if you were to have some turbulent blood flow through an artery, it makes kind of like a whooshing sound, and you're not supposed to have that in your neck because your arteries aren't supposed to have turbulence up there. This can be significant in some forms of thyroid cancer where you're developing an increased blood supply and a blood demand because of the tumor load. So you can have more abnormal blood flow in the neck that you're not supposed to have. And that can manifest on an exam as a bruit. To clarify this a little bit more, I have this little video that I got from Amboss. So we're going to watch that. It's just like a minute long, so it's pretty short. And if you guys can't hear it, let me know. Can't really hear it. Let me turn up my own volume.
Since the thyroid can be palpated bilaterally below it.
Is this better?
In healthy individuals, the thyroid only weighs around 18 to 25 grams and should not be visible. An enlarged thyroid, otherwise known as goiter, is considered class 2 if macroscopically visible. When the head is reclined, thyroid enlargement can be seen even earlier. Palpation is usually performed from behind, although anterior palpation is also feasible. The gland is often only detectable upon palpation if a pathology is present, such as nodules, enlargement, or an altered consistency. You should also note any tenderness to touch, as seen in inflammatory changes, such as a viral infection. To assess the mobility of the thyroid gland, ask the patient to swallow and offer a glass of water if necessary. If thyroid perfusion is increased, like in Graves' disease, examination may reveal an auscultable bruit and a palpable thrill.
Okay, so did I lose my? Oh, okay, sorry, I have to restart the thing. So just to recap that video, our patient had a non-tender thyroid, meaning that it's likely not some sort of acute inflammatory or viral cause. The thyroid was palpable, so we could feel a nodule on the right side. So that indicates something that abnormal is going on. Otherwise, we wouldn't have been able to feel her thyroid. And she doesn't have any thrills or bruits. So that just kind of gives you guys a visual on what an exam looks like. And yeah, we're going to go from there. I mentioned earlier that she had a supraclavicular lymph node. And I just wanted to point out that there's these different regions of lymph nodes in the neck that are classified by their location. And the ones that we associate with being like cancer or malignancy or metastasis, especially with the thyroid, are these supraclavicular, or the ones that are above the clavicle, above the collarbone. And the ones that are more high up, like these anterior cervical ones that are kind of just in the middle of the neck, or the ones that are just kind of under your jaw, those tend to be more associated with viral infections like strep throat, mono, things like that. Also, I said viral infection. Strep throat's not a virus, but just like general infections. So sorry for the mix up, but the big distinction here is that we're kind of seeing a red flag that she has a lymph node above her clavicle. So for our workup, generally a good jumping off point is to do things like a CBC, which is a complete blood count. That was unremarkable. Her BMP, or her basic metabolic panel, was also unremarkable. These are not very specific or sensitive for thyroid in general, but they can kind of give you a good starting point, and they're also very easy to do and inexpensive. Her thyroid labs, which is free T4, which is thyroid hormone, and TSH, or thyroid stimulating hormone. These are specific to the thyroid. And as you'll notice, they're actually normal. So her TSH is maybe a little bit elevated. It's the upper limit of normal, but we're still not calling it abnormal or high, which might be a little surprising. I did not know before going into med school that you can have like a cancer of a specific organ, and then those markers are normal. And it really just comes down to the functionality of that. So if she does have a cancerous process going on, whatever is growing in a tumor is not producing that excess hormone, essentially. So overall, labs look normal and not really helping us figure out what's going on. Does anybody have any other ideas on tests that we could do to try to narrow down what might be causing her lump in the neck? Seema said ultrasound. I love it. Ultrasound, biopsy, and you guys are exactly right. We're going to actually do both. Ultrasound is a great first line test because it's super inexpensive, easy to do, accessible in most hospitals. They also do not have any radiation. So you can just do them in the office and there's no risk to the patient at all. And they kind of determine what your next steps are going to be. So depending on what you see on the ultrasound, you might do like a iodine uptake scan, you might do a biopsy, just kind of depends what you find on this first test. And then, like a lot of other people said, to do a biopsy, the fancy medical name for this type of biopsy is a fine needle aspiration. So instead of cutting open the whole neck and the thyroid and taking like a excision of it, they're just going to take a needle and suck out some of the abnormal cells. And this is the gold standard for the diagnosis of thyroid cancer because you can really see at the microscopic level what these cells look like and the pattern of growth that they're displaying if it's concerning for cancer. So this is an example image of what an ultrasound looks like of the thyroid, specifically in a abnormal nodule. So this darker area that you see in the middle here with kind of irregular borders, kind of irregular coloring, or echogenicity is the formal name for it. That's the nodule that we're interested in. And you can see that there's these little white areas kind of scattered throughout. Those are little areas of calcification, which are pretty concerning for a tumor because the parts of it inside that don't have enough blood flow and nutrients to it because it's growing so rapidly can actually have like necrosis and die off, and then they calcify. So seeing this like irregular shaped with these calcifications is pretty concerning for a tumor that is malignant. So the next step would be to stick that little needle into the middle of the nodule and take a sample of those cells, and then be able to look at those under a microscope for any abnormal activity. Madeline's asking, is that how you end up with a cylindrical core biopsy? I think that like a core biopsy, I know they for sure do that in breast cancers. They don't do the fine needle aspiration. So I think it might be dependent to the area that you're concerned about. But the core biopsy, as you can probably tell by the name, is going to take like a larger section of a more, I don't know what the word, like to try to preserve more of the tissue versus just taking the cells and not maintaining their architecture. So I think it just depends on the area that you're trying to biopsy. That's a great question. So for our assessment and plan, we have a 27, I said 27 now, but it was supposed to be 24, my bad, you guys. But this is a 24-year-old patient with a 6-week history of a slowly enlarging supraclavicular lymph node and a right-sided thyroid nodule. She has no other associated symptoms. And on her physical exam, it was, just a couple centimeters. So an ultrasound that we did demonstrated a 2.1 centimeter hypoechoic intralobar mass, and the fine needle aspiration cytology confirmed a diagnosis of papillary thyroid carcinoma. So that's kind of just a summary statement of the sequence of events. It has her chief complaint. It has what we did for her and the test results that were able to help us come to the conclusion of a diagnosis. And then the next thing, the last part of the SOAP note, is the plan. So our patient is going to undergo a total thyroidectomy with a neck dissection. So the thyroidectomy portion of the procedure is to just get the thyroid out, and then the neck dissection is to take out any abnormal or enlarged lymph nodes so that you don't have continued spread of the cancer through the lymphatic network. Does that make sense? Does anybody have any questions right now? And if there's anything on your SOAP note that you're missing or that I went too fast on, then at the end of the presentation, we can absolutely go back and get you any information that you needed. But the note is really just like a thinking exercise to help you kind of go through the process, and it's not a significant part of your grade for the certificate. No questions? Okay. If you guys think of any, I can totally go back and we can revisit something that we've already passed. So now we're going to jump a little bit more into the pathology and the procedure of a thyroidectomy. So for thyroid cancer, the risk factors for that is being female. So females have an almost 3 times higher risk of thyroid cancer compared to males. And the peak age incidence is 30 to 50 years. So actually pretty young compared to other cancers. We associate them with people who, as they age, they accumulate more mutations, and thyroid cancer is one of those that you can get earlier in life. Also, thyroid cancer typically presents asymptomatically with normal thyroid labs. So the next slide, I believe I have like a outline of what the signs of being in a hyperthyroid state and the hypothyroid state are. And typically these symptoms are absent in someone with thyroid cancer. They might also have normal thyroid function tests, so you wouldn't necessarily see that on lab work. Thyroid cancer is also the most common endocrine cancer in the United States. And additional risk factors, along with being female, is to have any history of radiation to the neck and family history of thyroid cancer, having a genetic predisposition to that. So there's 4 main types of thyroid cancer. This little graphic over here only has 3 of them. But the one that our patient was diagnosed with is papillary thyroid cancer. And this is the most common type of thyroid cancer, as well as the one with the best survival rate. So about 95% of patients who have papillary thyroid cancer will fully recover from their disease. And you'll see here that some features of papillary thyroid cancer are that you get these lymph node metastases. The other types of thyroid cancer aren't as relevant for this presentation, but we have follicular thyroid cancer, medullary thyroid cancer, and anaplastic thyroid cancer. So medullary thyroid cancer is associated with familial mutations, and you can have a disease called multiple endocrine neoplasia. That one is more severe, and it's also more rare. The most rare and the most severe with the worst prognosis is anaplastic thyroid cancer. So we see, people with less than 10% survival rates of this type of cancer, which is, really, really striking compared to the other types, which have good prognoses. And again, that's because they have just a more aggressive course of metastasis. So just for now, we'll focus on the papillary thyroid cancer. As I said earlier, I was just going to try to review super quick some of the hyperthyroid and the hypothyroid symptoms. If you're overwhelmed with information, then this is not really part of the talk. I just wanted to, for completeness sake, at least address it. And if you're interested in thyroid disorders, Emma has a great virtual rounds on YouTube that I think was back maybe in March of last year. And she'll go through these different states as well as the causes for them in a lot more detail. So quick plug for her. But really quick, just to review, being in a hyperthyroid state is going to essentially just turn everything in your metabolism up. So your heart rate's going to increase, your blood pressure is going to increase, you're going to be sweating a lot, you're going to be losing weight, have intolerance to heat. So if it's normal room temperature or slightly warmer, you might be really sweating and uncomfortable. Same with your GI system. Everything's going to like get sped up and you're going to get diarrhea and things might just go right through you, get some stomach cramping. And neurologically, you might also get like a hand tremor, have like some anxiety, and your reflexes will be exaggerated. So hyperthyroid, everything is just really high. Hypothyroid, on the other hand, is everything's going a lot slower and turned down. So you have a low heart rate, a low blood pressure. You might be intolerant to the cold. So again, like if you're just in a normal room, you might feel like you need a blanket or you want to turn the heat up. Typically, you also gain weight with being hypothyroid and have constipation. Things are just kind of moving through you slower. And as opposed to having anxiety with hyperthyroid state, you would get something more the picture of depression or having like a flat affect. And then these other things are not really specific, but sometimes with hyperthyroid, you can get these like bulging eyes that are just kind of like, I don't know, very aggressively staring. And with hypothyroid, you can get these like dry skin, brittle hair, and nails. So that's all the time that I wanted to spend on this, just as a really quick refresher. If you guys wanted to hear about that, then just go to see Emma's talk. Okay, but now for the main part of this, because this is a surgery talk after all, and I am interested in doing general surgery. So this is the part that is exciting to me. So I have this little diagram of the anatomy of the thyroid over here. I think anatomy is probably the most important thing that you can do to prepare for surgery. You want to know where you're going to be, what's going to be in that area, and the things that you need to make sure you avoid. So the neck is obviously a very vulnerable place in the body because there's a lot going on there, a lot that's like vital to your life and maintaining your vital functions. So the thyroid is a kind of bow tie shaped gland that sits right below the thyroid cartilage. You can kind of feel that on your own neck. It's the like the really main hard bump that just sits kind of maybe a few inches under your chin. And just below that is the thyroid. It has two lobes that are united by this central isthmus, and it has a lot of metabolic functions around it. So the thyroid gland derives its blood supply from the carotid artery and the subclavian artery. So knowing the blood supply is again very vital, so you don't like cut where you aren't supposed to and the patient starts bleeding profusely from an artery. And in the same region, we have the jugular vein as well. So when you're making your incision, which is going to be a horizontal incision in the front of the neck, you go through the superficial layers of muscle. So you have kind of like your, I don't know, like your sternocleidomastoid, which is the one that kind of pops out when you turn your head, and your platysma when you flex your neck like this. It's this really thin overlying one that you can kind of make a weird face and it comes out to say hi then. So when you're retracting over those, you want to be careful of the jugular veins and the carotid arteries that you don't damage those vessels because they're the like main vessels to the brain. Next, you're going to retract over the hemithyroid lobe to expose one side at a time. So when you're working in the neck, you don't have it just like super wide open. You only do one side at a time to make sure that you don't have too much going on. Next, you're going to cut the isthmus to divide the gland. And that will, again, just give you some more mobility and some more visibility in your field to work with. And then since you're working on one side at a time, you just take out each lobe one at a time, essentially. And during this process, you're also looking for lymph nodes. So during a process like cancer, a lot of the times the lymph nodes are kind of enlarged in like a chain. So sometimes you can pull out like a big chain of like 5 or 10 lymph nodes that are all kind of stuck together. As you're closing, again, because you have a lot of arteries and veins that are ligated and you want to make sure you have good hemostasis. If you have excessive bleeding, especially as you close, that blood has nowhere to go and you can get just like this expanding hematoma in the neck, and that can compress the trachea, which is right underneath the thyroid. So as you're closing, you want to pay very close attention to make sure that you're not bleeding into under the skin and causing the compression of the trachea, because that would be a really terrible emergency. And then lastly, you suture and close the skin. And the whole thing takes about 4 to 5 hours, depending on how, I don't know, how like clean your field is and how many lymph nodes you have and things like that. So that's just kind of a quick overview. Obviously, like in real life, it's a little bit more complicated, but I feel like hopefully this anatomy is not too complex. The main things here are, this is your landmark, the thyroid cartilage, the thyroid having the 2 lobes, the blood supply coming from the carotid and the subclavian. And we'll talk about some other complications here in just a second. Megan is asking, would you always put a drain in for the excess blood? That's a great point. So I would say that in other neck surgeries that I've seen, they do put in a drain to help get any like excess fluid out of the neck. But with a thyroid, typically it's more anterior and your incision is pretty small, actually. It's probably less than 4 inches. So there's not a whole lot of room in there. And they do spend a very meticulous amount of time going through and seeing each tiny, tiny individual blood vessel and making sure that it's either tied off or cauterized, so you don't have that excess bleeding, versus some other procedures where it's maybe a little bit more like quick and dirty. Not to say that, surgeons aren't precise in what they do, but this is just such a particularly sensitive area that even with, such a small field, they're going at such a slow pace and making extra sure that they don't have any bleeders into the surgical field. So I'd say, yeah. So for other types of neck surgeries, you can use a drain, but for a thyroid surgery, I'd say less likely. Yeah, great question. I did want to show you guys kind of some pictures of a real surgery. So if you are squeamish with blood, I mean, I know that we're all either pre-med or like in medicine here. And so I don't no shame if you're not into this stuff, because some people want to be psychiatrists and not deal with this, but I just wanted to give you a heads up. So if you don't want to see that, then just maybe turn your screen off for a few seconds, but pretty much just this is it. Your field is pretty small, like I said, and it's not nicely colored like this anatomy photo that I had before, where you can see like, oh, the artery is red and the vein is blue and the nerve is yellow. In reality, it's all just kind of one big mess, and blood gets into your field and things kind of get mangled and, all that good stuff. So just to show you guys kind of what it really looks like, here's a couple of things pointed out. So the recurrent laryngeal nerve, this little thing that kind of dives down into by the trachea on this side, looks pretty similar to the superior thyroid artery, if you ask me. So sometimes it's hard to tell the difference between different structures. And yeah, usually the med student's job is to retract so that the attending and the resident can have a good view. So I've held open fair share of thyroid or muscles that cover the thyroid, and they do all the fun stuff, but at least you get a good view. If you just close your screen to avoid the blood, then we are done with that screen for now, and there will be no more blood for the rest of the presentation. But I wanted to touch on some complications of doing a thyroidectomy, because again, we're in a very vulnerable place in the body. We don't want to be making mistakes here. The first thing that I would say they take the most amount of time to avoid injuring is the recurrent laryngeal nerve. So this is a nerve that runs kind of behind the thyroid and to the side. And its job is it innervates the vocal cords. So if you sever this nerve or cause an injury to it, then that side of your vocal cords will just not move. They won't work. That can manifest as either voice hoarseness or vocal cord paralysis. And if you cut both of them, then you can also just like close off your airway. So very, very, very important to avoid injuring the recurrent laryngeal nerve. The second thing I kind of already mentioned was if you have a subcutaneous expanding hematoma, that is a risk of compressing the airways. So after we close the incision, usually the surgical team doesn't scrub out and they hang around for a few minutes to make sure that there's not like a growing like bruise or mass underneath the skin that would warrant opening them back up again and trying to get better control of the bleeding. Luckily, I've never seen that happen before, but yeah, it's always something that we watch out for. And then I don't remember who it was. It might have been SEMA, possibly. I don't remember, but the parathyroid glands. So again, people forget about them. There's these four little guys that hang out on the back of the thyroid, and they're about the size of a grain of rice. So they're very small, and you can't really tell them apart from everything else that's going on, like I showed you in those pictures before. But unless they have a parathyroid cancer, we want to leave them in because they still do a vital thing for our body. They are responsible for controlling calcium and phosphorus homeostasis. And so a common complication after a thyroidectomy is if you accidentally remove or damage one or more of these glands, then you can have hypocalcemia or low blood calcium level in the first couple of days after your operation. So the signs that we look for low calcium would be numbness and tingling of your lips and fingers. That's a question that they always ask at rounds the day after surgery. And basically what they'll do is supplement with calcium to bring your levels up until your remaining functional glands kind of catch up and are able to produce the proper amount of parathyroid hormone to maintain that normal balance. So hopefully that explains a little bit more about the parathyroid glands, but they're typically just very small, kind of hanging out in the back, and they have a more, I don't know what the word I'm like, homeostasis of these electrolytes specifically. Okay, so we're almost done here. What time is it? Do a quick check. We're making good time. Hopefully I'm not going too fast for you guys. Are there any questions right now? Anything you want to go back to? If not, we'll just keep trucking on. So in a person with thyroid cancer and who undergoes a total thyroidectomy, after their surgery, they stay at least a day in the hospital and again, just kind of monitor for any signs of airway compression would be the most immediate and life-threatening complication. Make sure their calcium levels are doing okay. And once they get sent home, just typical instructions for healing after a surgery, trying to prevent infection, do good aftercare so that you have a nice cosmetic result and your scar can heal as well as it possibly can. So they'll typically have like a post-op check a couple weeks after the procedure to make sure that everything is going okay with the healing process. After that, it's typical to have a yearly ultrasound or a yearly exam with your surgeon to monitor for disease recurrence and make sure that you are still in remission and don't have any other signs of cancer returning. There are a couple adjuvant treatments for some cases of thyroid cancer. Some people are candidates for radioactive iodine therapy or radiation therapy, especially people with metastatic disease. But this patient in particular, it was just localized to that one lymph node and she didn't have to undergo any additional adjuvant therapy. And then I mentioned before that there's the different types of thyroid cancer. If you have specifically medullary thyroid cancer, then that can be associated with other sites in the body that have tumors. So we also want to make sure that we perform surveillance for those possible areas of future cancers as well. But because this patient had papillary thyroid cancer, she doesn't have to undergo that. All patients who have a thyroidectomy no longer have a thyroid. That's kind of the point. And they stop being able to produce thyroid hormone. So they have to be on lifelong thyroid hormone replacement with a drug called levothyroxine. And again, that's just going to help mediate all the metabolic functions of the thyroid that you otherwise would not have if you didn't take this. So as an update, our patient had no surgical complications. She recovered back to baseline in 2 weeks of post-op and just had a check back in December, 3 years after her diagnosis, and it showed no evidence of disease recurrence. And she is now a third-year medical student. Not all the details are the same, but this actually was modeled after one of my best friends from med school who did actually have papillary thyroid cancer. And has, like I said, been free of disease. So, some details I just kind of changed around and made a little bit more or less interesting. But yeah, it's actually something that people our age can have. And so hopefully this was relevant to you or your future patients in some way. So last thing for you guys is to do that 10-question quiz. If you are looking to get one of those certificates of completion, if you don't get over an 80% the first time around, then you can try it again. And if you need a copy of this presentation to kind of go back and find details or to help you with that quiz, then I can put that in the chat. The Google folder also has a bunch of resources for abbreviations and lab values and things like that to help you if you need so. I always also, sorry, went too far. I always also really encourage you all to fill out the feedback section of the form because that's essentially how I choose my topics to present on. If there's anything that you are personally interested in, like any areas of medicine or like a disease or any of that sort of stuff, then please suggest it because that's, like I said, literally how I pick my topics. So give me some inspiration, please. And if there's anything that we can do better for you to make these either more interactive or more educational, if it's too hard or too easy, just make sure to include that as well so that we can really tailor and make this experience as helpful as it can be for you all. So that's all that I have. I know we finished a little early. It's 8:47 right now, and we're scheduled to go until 9. So if there's any slides you'd like me to go back to, or if you have any questions, even if they're not related to this topic, if it's just about medicine or medical school or anything in general, where can Mina find the quiz? Let me copy and paste that back for you. Oops, hold on. I'm getting it from the chat quick. Okay, so you should be able to access the quiz by clicking the link that I just put in. And if it's not working for any reason, just let me know. Any other questions you guys have about anything? Is levothyroxine normally made by the thyroid gland? So thyroxine is made by the thyroid gland. That is the name of thyroid hormone. Levothyroxine is just the synthetic version of thyroxine. So the name itself is a little bit different, but it's essentially the exact same molecule that's able to perform the functions that endogenous thyroid hormone would have. What other questions do you guys have? I don't know if any of you are currently in an application cycle right now, but if you are, I have been thinking of you all and rooting for you. I know that it's quite a long and anxiety-provoking process. So if you ever need to get some extra support or process with anyone, I would be happy to help you or connect you with someone who is on our team. Oh my gosh, Adam got accepted to a post-bac. That's so exciting. Congratulations. Great work. Yeah, any applications, not just for med school, but for gap year jobs or post-bacs or, there's a lot of things. So moves are being made by a lot of people. And I also wanted to say that if you are done and don't want to hang around, then please feel free to log off the Zoom and we are done for the day. But I'll be available probably for the next 10 minutes or until people start leaving. And it's just me. Again, if you have any questions that's either related or not related to this topic, then I'll hang around. Yeah, thank you all so much for joining. I really enjoy doing this, and I hope that you guys enjoy learning about these topics. I always want to give you guys so much credit for putting yourself in this position to learn about very advanced topics in medicine that medical students typically don't learn until their second or third years. And if you guys are keeping with it like this, then that's a great sign that you are going to be well prepared for the intellectual demands of medical school. So I'm always so impressed with you guys and for your commitment to come to these things. Yeah, I look forward to seeing you all next time as well. I don't know if it's next week or the week after that, but I'll be back doing another one. Megan missed about the radioactive iodine and radiation therapy. Yeah, so it really just depends on, yes, you're correct, the type of cancer. So if it's papillary or if it's medullary or anaplastic, that can factor into it as well. And then how advanced it is. So if our patient here just had the thyroid nodule in one lymph node, then that wouldn't necessarily put her as a candidate for that adjuvant therapy. If she had a lot more lymph nodes that were like had the cancer in it, then that might be a criteria for her to get the either radioactive iodine or radiation therapy. So it really just depends on the severity of the disease. When there's accidental damage to the parathyroid, is there any treatment to manage the phosphorus levels? Yeah, that's a really good question. I think that clinically, I haven't seen phosphorus replacement as commonly used as calcium replacement. I think that it doesn't present as clinically in terms of symptoms that happen. So you don't get that classic like lips and fingers numbness and tingling with a phosphorus deficiency. And I think that, and I don't know this for sure, but maybe that the kidneys are capable of sort of recovering the phosphorus better than they are at recovering calcium. That's just a guess that I have. But to answer your question, I have not seen within the first couple of post-operative days that they have a need to replace phosphorus. And I think that also ties into the other roles of calcium. So you can have there's more room for error, I suppose, with phosphorus levels in terms of your body's functions, whereas with calcium, there's kind of a tighter window of what you need to have in order to maintain your functioning. So if you have like severely, really low calcium, then you can have some pretty profound neurologic effects of that. And I don't know if there's as severe of a need with low phosphorus. So I don't know if that was a good answer or not, but you're thinking the correct way. It's just that I don't know. Are the parathyroids connected to the thyroid? Yeah, they are. They are kind of like nestled in the thyroid, not like inside of it, but just kind of embedded behind them. So they're not just free floating necessarily behind, but they do kind of sit just right on the back. I don't know what else to compare them to. Like, I don't know, maybe an enamel pin on a backpack. Is that a bad way to explain it? Yeah, so when you're doing the dissection of the thyroid, and kind of making sure that all those little blood vessels are ligated, they can come off and they look very indistinguishable a lot of the times from the rest of the surgical field. So yeah, they do kind of get knocked off. And again, they're so small and everything's kind of just like colored in blood a little bit that you can very easily mistake it for just like a piece of fat or part of the thyroid gland itself that has just come off. So yeah, they do have to like manually be knocked off per se. And that's just kind of a part of the process. But a lot of the attendings that I've worked with have a skilled enough eye and enough experience doing this operation that they are able to kind of distinguish either based on look or feel or just anatomic position of what they think is a thyroid gland, or sorry, parathyroid gland. And to be extra sure, sometimes you can take a little tiny microscopic biopsy of it and send it to the pathology lab to see if they can confirm the types of cells that are in it, if it's actually parathyroid or if it's something else. And then you can, have confirmation that that's what it is.